Good afternoon, good evening, good morning, wherever we may be in this space. We do apologize for this delay. I'm sure you are all aware of what is happening in Nigeria, but we thank God that a few of us are able to get to this place. So we'll be starting in another 2 minutes. All our members online who are on the program, they are ready. I thank you for the understanding. God bless. We'll now call on our elder, our matriarch, the first MWAN president in Oyo State. Without Professor Oluni, there is no MWAN. Without the founder, Professor Odunton, there is no MWAN. So we really thank God for the presence of these our mentors who are well and alive. And we also thank God for the life of the BOT chairman, Professor Elebute. We'll be telling you more about all our elders and members and about this meeting shortly. Can we have the opening prayer from Professor Oluni? Thank you.
Our Father and our God, we want to thank you for the opportunity of meeting this afternoon. We want to thank you for the safety in an unsafe country. I realize that some of our members are unable to join because of the disturbance in town. We have at least over 50 participants. Thank you, God, for making it possible for us to meet. We want to thank you for our presenters who have taken the trouble to prepare the subject that we are considering this afternoon. As we start this program, we ask the good Lord to lead us so that the presenters can be able to pass on to us what presenters. Thank you, Lord, as we start. Please lead us in this journey. We pray in the name of Almighty God. Amen. Thank you.
Amen.
Good afternoon, our elders and members of the IT board. We thank Professor Oyin Elebute for the opening prayer. Next on the item is Oyin. Okay, thank you for the correction. Please let's rise up for the national anthem. Thank you very much. May we have our seats, please? I want to welcome you all to today's webinar, which is being organized by the Medical Women Association of Nigeria, National, and the Elders Forum, ably led by Professor E.O. Elegbe. The next item is to introduce our invited guests who are already seated on the high table. I want to welcome the chairman of today's occasion, Emeritus Chief Medical Director, Professor Temitope Alonge. You are welcome, sir. A round of applause for him, please. Okay. I've just been corrected that Professor Temitope Alonge is a special guest, while the chairman of today is Professor Adenike Branch, the former Minister of Health, Nigeria. Also seated on the high table, we have the National President of Medical Women Association of Nigeria, my mommy. Good afternoon, Dr. Adekemi Otolorin. You are welcome, ma'am. And the host for today is our mama, Professor Eniola Olanrewaju Elegbe, coordinators of the National Elders Forum. You are welcome, ma'am. And to do justice to the topic of today, which is the burden of osteoarthritis in the older adults, is our consultant orthopedic surgeon in the University College, at the University College Hospital, Ibadan, Dr. Richard Omoyeni. You are welcome, sir. And as we know, it's not only medical treatment, you also need physical therapy when you are dealing with osteoarthritis. And to do justice to that, we have Dr. Adeshola Odoli, Associate Reader and Head of Department of Physiotherapy, and also a specialist in orthopedic physiotherapy. You are welcome. Now, the next item is a welcome address and the background of the events. And to do that, I want to respectfully invite our mommy, Professor Eniola Elegbe. Thank you.
Good afternoon, ladies and gentlemen, and our elders on the link. It's my great pleasure to be able to put together this program. It's taken us a while, but I just thank God I'm able to put this up, and I believe that we will enjoy it and we will learn from it. I promise you there are more to come. Thank you everyone for the audience.
Thank you, ma'am, for the brief background to the topic of today. Also, I would like to invite the National President, Medical Women Association of Nigeria, Dr. Adekemi Otolorin, for a welcome address.
To God be the glory. I recognize the presence of the founder, Medical Women, the first ever president, Professor Olurin, Professor Dunton, the founder, our BOT chairperson, Professor Elebute, all our elders, all our mothers in MWAN, past national presidents, all members of the Board of Trustees, past executives of the state MWAN, and all MWAN members. Again, I recognize the chairman of today, Professor Grange, our special guest of honor, an orthopedic surgeon of repute, Professor Alunge. The host, our mother, Professor Elegbe. The resource persons, without you we can't be here. We are very grateful. Members of the National Corps, Inner Corps, External Corps, MWAN, distinguished ladies and gentlemen. It is my pleasure to be here today to witness this first webinar of Senior Members Forum. We've been at it for quite a while, but we thank God that despite everything happening in the country, it has come to pass. Now, we all know the importance of good health. Without good health, we cannot function, we cannot be relevant in the society. So the earlier we have good education, the microphone, thank you. The earlier we receive the correct education about management of different parts of our body, the better for us. It will be a healthy nation, a healthy family, a healthy community. Again, I thank the National Coordinator for putting this in place. The topic is very germane because all of us, as we age, we tend to have such symptoms, including myself here. So I thank you all that are online. I wish to recognize Dr. Mini Oseji. The program started during her tenure, and I wish to recognize Professor Belgam, the first National Coordinator for the Senior Members Forum, and Dr. Ofo, the first Secretary of that committee. Please give them a round of applause. We, the present executive, we are building on the foundation that they have laid. Once again, I welcome everybody. I wish us a robust time in his presence this afternoon. Thank you very much.
Thank you very much, ma'am, for that welcome address. We recognize all the medical women online, the physiotherapists online. There's so many. The president of Oyo State Medical Women, Dr. Oyin Adeyemi, the immediate past national president, Dr. Minimi Oseji, all the professors here present online, we recognize you. And we welcome you to today's occasion. I would like to call on the chairman of today, Professor Adenike Grange, to kindly give the chairman's address online. Thank you.
Good afternoon. My dearest colleagues, participate. It's your my dearest colleagues, participate. It's your my dearest colleagues, participate. Is it all right? 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 Okay. The webinar, as we know, is in honor of the chairman of MWAN Board of Trustees, Professor Oyin Elebute. Let me, first of all, pay homage to all my senior sisters of the Board of Trustees and not of the Board of Trustees. I was there as a younger person when they were starting. I have to thank them for taking me then as their mentee, I would say. Thank you very much. When Dr. Tolorin, our indefatigable president, approached me to be the chairperson, I wondered why she was so directed to me, because she didn't even know that I had a special bond with the celebrant, Professor Oyin Elebute. Our bond went as far back as several decades at Luth. And it came to a crescendo in 2007 when she and her entire family, especially Fola and Kunle, unreservedly played an incredible supportive role in my appointment as the Honorable Minister of Health of the Federal Republic of Nigeria. I have since not had the opportunity to thank them for this publicly, but today I'd like to show my appreciation by thanking them and by wishing the president of our BOT, Professor Elebute, a long life, healthy, free from all the ailments of the aged. It may be that she will be able to play a limited role for a while, but I pray that God will restore her strength and health in good time. I do admire all these icons of mine who started the MWAN and who have been showing us what it is to grow old in the association and to continue to link up with those coming behind. And it is this example that I have tried to follow by keeping in touch with the association, even from afar. And I want to thank Dr. Tolorin for recognizing this and for always trying to engage me in all the businesses of the MWAN. Thank you very much, Dr. Tolorin. I think the saying goes that what goes round, what comes round goes round, or whatever, like something like that. And I want us all to realize that it is what we do today for our elderly that the younger ones will do to us in future. I must ask you all to relax now and listen to the experts who will enlighten us on one of the chronic problems of some of us who unfortunately may already have been incubating this condition due to genetic and environmental factors. Hopefully, the speakers, the presenters will be able to tell us how to redirect our lifestyle to that of the oldest female bodybuilder, Ernestine Shepherd of the Guinness Book of Records, who at the age of 86 years is still able to walk 10 miles daily and to do several press-ups in quick successions. we realize that this is a result of luck and dedication, as well as genetics. Thank you very much. Over now to my dear President to carry on with the presentations or the program so that the presenters can now make their presentations. Thank you. I do hope that you heard all that.
Yes, we did.
Okay, thank you. To call the presenters. Is that going to be one of my businesses? Okay. I would like to call on the first speaker, Dr. Richard Omoyeni, the consultant orthopedic hospital at the UC.
Now, before the presenter, we have some goodwill messages. One from Professor Johnson. If the connectivity will make us together, then from our special guest of honor, Professor Alunge, then from the representative of Professor Elebute, Dr. Dupe Elebute Odunsi, and then our host, Dr. Olowokere. Dr. Olowokere has been part of Medical Women in the last 2 years. He is our host today. We are in his premises, and he has done all whatever is possible to make us comfortable while the NMA building is being rebuilt. So we appreciate him. And then we also have from Professor Adeniyi, the Deputy Provost, representing the Physiotherapy Department, and finally, our umbrella organization, the NMA Chair, Dr. Lasisi. We will do all whatever we can in the short time, knowing that the situation in the country has taken the first 30 minutes from our program. Thank you very much. Please, can you call on Professor Dunton if she's online? And if she's not, then Professor Alunge, and then Dr. Dupe Elebute Odunsi, in that order. Thank you very much. She's not yet online. She'll give her message later. Then Professor Alunge. Professor Alunge is a revered professor of orthopedic surgeon and also the chair for the COVID pandemic committee in Oyo State. He's a man of many parts, and he has done a lot in the life of medical women. We are using this occasion to say thank you, apart from the fact that we are coming home to phones and PCs if you are in this hall. So we like to use this occasion to say we are back to you when it comes to all our bones and muscles. Thank you very much for coming to our aid. Thank you, Professor Alunge.
The National President of the Medical Women Association of Nigeria, my auntie, Dr. Otolori. Please, can you permit me to adopt the protocol that she has said, quite extensive, but I must recognize my teacher and our wife, Professor Mrs. Elegbe. She's an Akoko woman now, courtesy of the fact that we married her for so long. So I wonder whether she knows the route to Lagos anymore, but she's with us now. So Auntie me, God bless you, ma'am. And my colleagues, Dr. Richard Omoyeni, my colleague, and then Dr. Shola Odole, my friend of many years, and also a professional colleague. Age, they say, is in the mind, but geriatric care and pediatric care are the two age-related specialties. So it means that even though age might be in the mind, there are some other things that age also would connote. And so for older persons, which is the better terminology than the word elderly, which looks like they've been condemned, is very apt. And non-communicable diseases is a major concern all over the world, and osteoarthritis is actually high up among the first three in Nigeria, after hypertension. Diabetes is even not amongst the CADA in the first four. So today, I frown at the organizers who put the chairs here, because to my right and to my left are well advanced older persons. And they are not supposed to be sitting in chairs without armrest. And so Dr. Dele should mention that and then advise us on the kind of chairs they're supposed to give to older persons to try and help them in managing their osteoarthritis. Of course, everybody assumes that osteoarthritis is only restricted to the major joints of the body. But in the next couple of months, I want to embark on osteoarthritis of the fingers, which may not require radiographic evaluation, but clinical and pictorial views will give us the diagnosis so that we can have a complete picture. You know, so management ranging from changing of shoe wears, we have some genetic predisposition, so you must look at your mother-in-law before you decide to send Valentine card to a lady who looks very prim and proper today, but if you look at her mother and probably the grandmother, you either change your mind or reduce your dowry. And so this is a ubiquitous disease. Osteoarthritis is a ubiquitous disease. And so no man has a one care or one cure protocol for it. And so we're all going to be talking about it, and I'm very happy that we've brought in two combatants, one from the orthopod. The only person we've omitted is a rheumatologist. But I think the rheumatologist will not like to come because they probably will be feeling very uncomfortable with an orthopod next door. After all, when you finish all your injections, what do? You are stuck. Then they come to us and I do a total knee or total hip or corrective osteotomy. And when the orthopod has finished, and the physiotherapist says, but I told you what we should do pre and post management. The muscles were wasting away. You didn't listen to me. After you've put in 2 million naira implant, the patient is not working well. Now you are coming back to me. I want to thank the organizers for picking these two combatants, particularly Shola Odole. I think I was privileged to be part of her growth. But I'm very, very proud of her. And of course, for my colleague, Dr. Richard Omoyene, who is now my prodigy, I'm exceptionally proud of him. And so today I want to sit down and listen to, let them present their own part of the story. I think I'm aging as well, and I'm going to keep my own to myself. Thank you for inviting me, Ma, and God bless you. So I'm looking forward to a beautiful presentation. Thank you. God bless. Bye-bye.
Thank you. Next, we have Dr. Dupe Elebute Odunsi to give us a short goodwill on behalf of our beauty chairperson and also for herself. Thank you very much. Dr. Dupe Elebute Odunsi, please have the floor. Thank you.
Good afternoon. I hope you can hear me. You can hear me. You can hear me. Good afternoon. Good afternoon. Good afternoon. Good afternoon. Good afternoon. There's a lot of echo going. Sorry, once again, good afternoon, everybody. Well, I think that's better now. I hope you can hear me though. I'm not receiving any response back from anybody. Yes, you can hear me. Thank you.
Yes, we can hear you. We can hear you.
Brilliant. Thank you very much, sir. Good afternoon. My name is Dr. Modupe Elebute Odunsi. And thank you so very much for asking me to come and give a very short goodwill message on behalf of my mother, Professor Mrs. Onyade Elebute, who is the Chairman Board of Trustees of the Medical Women's Association of Nigeria. I want to stand on the already existing protocols, but in particular, I want to thank from the bottom of my heart, personally, but Dr. Otolori, who is the National Chairman of MWAN, Dr. Ibironke Shudende, who is the chairperson in Lagos, and also Dr. Osiji, who is the previous chairman, because all of you have been extremely, and through you, MWAN have been extremely supportive of my mom, who, as you know, is frail, as I think is the way I'm going to describe it. So she is very much aware that you're celebrating her today. We had a very long conversation about it yesterday, and also to thank both Dr. Otolori and Dr. Shodende, who actually came to visit her about a week ago. She was absolutely thrilled, and she's been talking about that visit ever since. So I want to say this is a fantastic program. It's a title that I think, as you said, speaks to everybody, and in the country in particular, and looking at I think I should also mention the impact that the COVID pandemic had really on her progress following. She had a fall 2 years ago and had her hip replaced, and she was doing very well from that. But then COVID happened, and as you know, we were all indoors, isolated, unable to actually interact with one another. And I think that was a significant issue in terms of her failure to maybe progress back to her original quality, very much. We give God all the glory. All her children, and I'm now a grandma, so her great-grandchild, in whom she takes a lot of delight. But to say thank you very much to the Medical Women's Association of Nigeria, to Professor Grange, and Professor twin sister. She has a lot of, tells a lot of stories about the time together and their growth in the organization and in healthcare in Nigeria. And all the speakers today, to all the attendees,
we now have the next speaker, Dr. Wale Lasisi, NMA, if he's online, and Professor Adeniyi of the Provost Office, if he's online too. If they are not, we go on straight to the first speaker, Dr. Oyin. Please, are they online? Can you check? Yeah, he has left. Okay. Can we have the slides of Professor Elebute, or is it not ready? Okay, still done. Let's start the lecture. Thank you. Yes, Dr. Omoyeni. We keep the citation. Dr. Richard Omoyeni. Thank you.
Thank you very much, ma'am. Please permit me to stand on the existing protocol. I remember when I was first told that I would be the one presenting this topic. I remember when I was called upon, I began to ask myself questions. Now, how do I cope? So I came here early enough to come and look around and see as the member of MWAN were coming in so that I could build my confidence. But when I looked up and I saw my mentor, who has gladly offered his shoulder for me to start upon, he spoke earlier on. So that further boosted my confidence. So I want to say thank you for coming. I've informed him earlier on that, look, I'm going for a presentation, and I thank God that he's here with us today. And gladly, he has laid the background by telling us that the nature of osteoarthritis, what we'll be talking about this afternoon. Please with the slide. So because of our time, we'll just go straight to the... Okay, so osteoarthritis is the most common form of arthritis and the leading cause of disability among thank you. Okay, yes. Okay. No, it's not there. Okay. I must say that while I was, build up to this program, while I was talking with Professor Elegbe, yes, I remember the first time she called me, she really made me feel comfortable, and ever since we've been conversing and preparing for this, the way she spoke with me, made me feel very, very comfortable to come around, because I'm going to be talking to some of my great-grand teachers and grandmothers here. So thank you, ma. And it's nice meeting you again. I've already been seeing the voice, hearing the voice, but I'm seeing the face now. It's hanging. So osteoarthritis is the most common form of arthritis. There are other ones, rheumatoid arthritis, we have septic arthritis, but today we are talking about osteoarthritis, and it's a leading cause of disability among the older people. It is a chronic medical condition that has become a public health importance in our setting, even globally. It is the leading cause of pain, disability in the Western world, and in our environment. And if you have seen people with osteoarthritis, you agree with me that the pain they experience is very devastating. And sometimes some of them, you see an adult crying because of pain. And studies have shown that 1 out of 3 people over the age of 65 are living with osteoarthritis with female preponderance. Those who have symptomatic nail osteoarthritis whose age are above 55 years account for 15% of the population. And some of the cases that have radiographic evidence account for over 80% among those who are over 75 years. The typical joints that are affected, any joint in the body, as long as the joint in the body can be affected by osteoarthritis, but the typical one that's common to us are the knees, hips, and hands, spine, and feet. But for the purpose of today's discussion, we'll be focusing more on the knee and the hip. The epidemiological studies that have been reported varies from one region to the other. The prevalence and incidence rates has been reported and they vary. It is, as the estimate depends on the definition, whether it is pathologic or whether you are considering the radiologic feature of the osteoarthritis or the clinically diagnosed disease, or which the population sample that is being considered, whether it is primary, whether the study is being carried out at the primary health center or tertiary health center, whether it is in the developed country or developing countries. And it also depends on which joint you are considering. So that is why the epidemiological study in terms of prevalence and incidence rates are varied from one study to the other. So prevalence of osteoarthritis ranges between 12.3%, according to the study done in France, which based on self-reported cases, to 21.6%, according to the study done in United States, which is based on the physician-diagnosed cases. And of course, we said that it is common in women than men. And it also has been alluded to that the risk of developing osteoarthritis increases with age. And usually the first symptoms shows up between the ages of 40 and 50 years. The incidence of new osteoarthritis is rising with the increasing average age of the general population. So we are beginning to see increased incidence of osteoarthritis of 4 joints. They said that some studies have shown that it is greater the incidence is greater in developed country than developing country. However, the study done in Iran show that it's higher in the rural community. The study done in the rural community in Nigeria, Southwest to be precise, which is the first community-based study done by Deronke and Alonge showed that the prevalence was 19.6% for those who have symptomatic knee osteoarthritis. And they said that 21.4% account for those that are found in females, while 17.5% account for those of the males. And the study also shows that 1 out of every 5 adults that is aged above or equal to 40 years in Nigeria has symptomatic osteoarthritis in this community. The similar study was carried out in the northeastern Nigeria, and it was found that 16.3% account for adults aged greater than or equal to 30 years with symptomatic osteoarthritis of the knee. And for those who are above 40 years, it is about 20.6%. This according to Akimpelu et al. And among this population, we have female accounting for 40.1%, male accounting for 13.5%. And that gives us the ratio of female to male of 3:1. Globally, the prevalence of radiologically confirmed symptomatic knee OA as of 2010 was estimated to be 3.8%. This is according to the World Health Organization Global Burden Disease Study. And of course, that of the hip osteoarthritis is much less lower, which accounts for 0.85%. the symptomatic osteoarthritis in the hand is less common, even though it can be very devastating in those that suffer from it. Typically, when you see a knee joint, you have, this is not following me. Okay. This. Sorry. Okay. Okay, this. Okay, thank you. So, a normal knee, I won't bore us with the anatomy because we are all medical people, but a normal knee joint or any joint comprises of two bones coming together, and that of the knee, particular, comprises of the patella, the femur, the tibia. So a normal joint has a smooth cartilage, the tendon, the ligament that contribute to the stability and efficient functioning of the knee joint. The muscles you see here, okay, I don't know if you can. So these muscles are responsible for stability of the joint, and they are also made happy or strengthened by the function of the knee. Once the knee begins to manifest one or other form of trouble, it affects those muscles, because the stretching and the contraction of the muscles are what keeps them healthy. Okay. Okay. Sorry. It's gone. Sorry, help me. Sorry. I guess I'm used to... Okay. Okay. Thank you. Permit me to move. Can I? So I won't, like I said, this is fine. So you can see the kneecap, the femur, tibia. These are the menisci. All these structures contribute to the stability of the joint and efficient motion across the joint. And if anything happens to any of these, that may trigger the onset of trouble in the joint. This is a bone-in picture of a typical normal joint. Okay, again, this is the cartilage, the meniscus. We have medial and lateral. So, thank you. Okay. It's not showing. Anyway. Maybe I should just stay with this one. What's going on? Okay. It's not responding. Is the system okay? Okay. Why is attending to that? So, when you see a typical joint, I mean, it comprises of some of those ligaments, the cartilages, the cartilage must be in good shape for the individual to enjoy motion across that joint. And apart from all the structures that support the stability of the joint, the muscles around the joint are also important. And that is why when Professor Longe was talking about the physiotherapy, that is why it is important when it comes to limb surgery or treating any limb disease. The role of physiotherapy is very, very important, because when the muscles are in good shape, then you can be sure that the rehabilitation of the patient can be made easy. Okay, are we good? So typically, an articular cartilage is composed primarily of type 2 collagen, proteoglycans, and chondrocyte and water. And healthy cartilage constantly is maintained by maintaining an equilibrium between each of the components, so that degradation of cartilage is matched with synthesis. However, in the process of osteoarthritis, the matrix metalloproteinase, which is the enzymes responsible for the degradation of the cartilage, becomes overexpressed, disrupting this equilibrium, and this results to overall loss of the collagen and proteoglycans. Okay, so as we age, these are some of the changes that is noted in the cartilages. The water content decrease, the collagens remain relatively the same, proteoglycans content decrease, the body synthesis remain the same. The chondrocyte size become increased while the number decreases. Then the modulus of elasticity also reduces. This is, you have gone a bit, go to the previous slide, please. This is what happened, the changes that happen as one ages. But in osteoarthritis, some of these, there are some changes that occur. The collagen becomes disorganized. The cartilage is no longer able to retain some of the water that make it to be rubbery, and the rubbery feeling begin to get lost in them. The proteoglycan content also begin to decrease. Proteoglycan is responsible for the strength of the cartilage, and the synthesis increase in order to match up with what is being depleted. But because this equilibrium is not able to match up. Okay, so these are some of the enzymes responsible for the degradation of cartilage, and we have other enzymes that try to counter the excess degradation, but this equilibrium is lost over time. The pathophysiology of osteoarthritis involve the degradation of cartilage, just like I said, and the bone trying to remodel due to active response of the chondrocyte in this articular cartilage and the inflammatory cells in the surrounding tissue. That is why the osteoarthritis is not just disease that affects the cartilage, the surrounding muscles, the ligament are also affected. And that is why you see the knee or the particular joint affected become stiff. Apart from the pain that the patient experiences, those muscle structures around it are also affected. The exposure of the underlying subcondylar bone results in sclerosis and reactive modeling changes that leads to the formation of osteophytes, all in the bid of the bone to repair itself, and subcondylar bone cysts. And the joint space is progressively lost over time, such that the patient begin to hear crepitus, bone rubbing bones, and ideally, this should be the. I'm not saying the. Okay, this should be the normal joint, but this is what osteoarthritis end up giving to the individual that suffer the disease. And you can see it's looking ugly, and the pain is as ugly as it looks, because some of the cartilage had been eroded. So you see the nerve endings here being exposed, rubbing the other one, the nerve ending on the tibia. So any little movement elicits a very severe pain, and the patient mobility is severely impaired. And this is this is the radiographic feature. Again, this is the normal bone, but as one ages, this is what we have. The reduced joint space, you can see the osteophytes, and this just explains stages of osteoarthritis. Let's go to the radiograph because of that time. Okay. So, see, this is grade 0. This depicts the early signs or the early features of osteoarthritis, but as the thing progresses, it becomes moderate, grade 2, then severe is grade 3 and grade 4. You can see the joint space reduced, see the subchondral sclerosis, and some of the features that is expected in arthritic joint. So the risk factors are divided into major 2 groups: the personal level factors and joint factors. And so we have age, which this one you cannot modify. They are not modifiable risk factor: age, gender, obesity, genetics, diet, and the rest of them. Okay. So age has been found out to be the main risk factor. Even though the suspected mechanism has not been fully understood, but it is suggested that it's probably due to multifactorial problem: oxidative damage, thinning of the cartilage, muscle weakening, and reduction in the proprioception. The sarcopenia, which is the reduction of the muscle bulk leading to imbalance of muscles, can also increase the risk of developing osteoarthritis. Quadriceps weakening observed in most of them is due to this problem. And of course, because of the muscle not being used, there's disease atrophy. Weakness results in the lack of stability, which form a vicious cycle, worsening the problem. And this we should bear this in mind when it comes to rehabilitation, that is a very important component of treatment. Gender, we have said that it's higher in female, and the incident is probably, the increase in incident is probably due to menopause, because that is noted around the menopausal period. And the hormonal factor has been pointed as one of the causes that are responsible for increase of this osteoarthritis in women. Other factors is what has been highlighted. Obesity: a woman with body mass index of greater than 30 kilograms per square meter has been said to be strongly associated with knee osteoarthritis. Obesity is also associated with hand osteoarthritis, but that of the hip osteoarthritis, the association is weak, and the reason is not understood. Genetic factor has been alluded to. It is said that it is responsible for 60% of those with hand and hip osteoarthritis, while 40% is for those who have knee osteoarthritis. Many genes have been said to be playing a role in the disease onset. And this has been said that it could provide a target for future pharmacological treatment, e.g. a gene encoded for vitamin D. If this is established, that can be used to treat osteoarthritis. Diet is also some of the factor that has been implicated. Okay, this is joint level factor, injury to the joint, especially the anterior cruciate ligament, is often associated with cartilage damage. And this leads to early onset of knee osteoarthritis in 13% of cases after 10 to 15 years. If an individual sustains injury to his ACL, it is a recipe for early onset for osteoarthritis. And I'll just move because we are still going to the building. So malalignment, once there's one of the things that help in the congruity of the joint is when the mechanical axis is in alignment as it's supposed to be, so that the compressive stress is not biased to one side or the other. But the moment there's malalignment, then that can trigger early onset osteoarthritis. And it is said that the medial compression of the knee osteoarthritis is 4-fold greater in patients with varus deformity, that is, those who have bow leg. So the medial side of the tibial plateau compartment bear the greater brunt of the malalignment. Then for those who have valgus deformity, is 5-fold greater. What are the clinical features generally for osteoarthritis? It is, the onset is gradual and it worsens progressively, especially with prolonged activities. It works with repetitive bending and stairs. That's why we discourage some of the exercises that will require that a patient bend, squat, because it's like loading the joint almost times 4 of what you usually bear when you stand. It worsens over time, and it gives some relief at the early stage when the patient decides to rest. And it can respond to ice or some anti-inflammatory medication at the initial onset. Then associated with knee stiffness, knee swelling, decreased ambulatory capacity. This is the most annoying, that makes some of the patients present and say that, look, some of the things I used to do, I can't do them anymore. And that can be very devastating. They complain bitterly, especially those who have been active over the years. So this is just a distribution of those who, the symptoms they present with. Pain is constant, 100%, irrespective of the stage. Pain is constant. Swelling may be present in about 44.1%. Crepitus, that is joint making noise, in 77.9%, and the rest. Okay, there are some special features in osteoarthritis of some other joints. This is Bocas node is noted in proximal interphalangeal joints. You know, Prof was saying that he wanted to start collating some of the osteoarthritis of other joints to see what is the prevalence will be. We have always been concentrating on the knee and the hip. But how about the other joint, the fingers, the ankle, and the other joints in the body, elbow? So the Aberdeen node is seen in osteoarthritis of distal interphalangeal joints. Flexion deformity, varus malalignment in the knee, crepitus, I've said this before. So investigation primarily to make diagnosis of osteoarthritis is clinical diagnosis. The investigations you do is to exclude other differentials. Routine blood tests also to exclude some inflammatory problem like septic arthritis, rheumatoid arthritis. And of course, radiograph is important to confirm your diagnosis or to exclude fracture. Typical findings on radiograph: you have the joint space narrowing, you have osteophyte formation, you have subchondral sclerosis, and cyst. By the time it gets to advanced stage, you begin to see these features. And this is what you see in the hip. The joint is completely obliterated. And you see multiple cysts and the subchondra is sclerosed, and you can see some of the, at the edges, the osteophytes. Then look at the elbow, same thing. This is the ankle, and look at a normal knee and diseased one. Those features are prominent and they are common to all. The burden of osteoarthritis can be divided into the burden in disability and in mortality, then economic burden. This has been documented in various studies, and the osteoarthritis is responsible for activity limitation, and that will tell you how much it can take from an individual who has suffered incapacitation as a result of this problem, particularly in walking. When you are created, when you were given birth to, one of the things a parent look up to is when you begin to walk. And the first day a child raises the first step and begin to walk, even though he falls, they are not afraid of the child falling. They just want him or her to start ambulating because you are created to move. The moment that right that has been given to you by God begin to get compromised, then trouble starts. So people who presented with osteoarthritis were most twice as limited as those without osteoarthritis in walking and carrying objects. That's according to the Disability Health Survey done in France. So, and about 8.9 are not being able to walk. But osteoarthritis, as it progresses, it reduces the working capacity of the patient. 80% is responsible for difficulty in carrying objects, especially that of the hip, joint hip osteoarthritis. 12.8% is responsible for difficulties in dressing, according to the study done in France. And these findings are similar in other clients. Even though we still need to do more national studies to conclude on our own. So the mortality burden, it is said that higher risk of mortality than the general population is noted among those who have osteoarthritis. Maybe because the mobility is significantly reduced, and once the less mobile you become, the more risk you have in falling and even living long. I mean, once you cannot move as you want to, it becomes the risk of dying premature death is higher, and you can account for excess or cause of mortality. In other words, that is mortality that is brought about irrespective of other comorbidities that is found in that individual. If there's osteoarthritis along with those comorbidities, it increases the chance of that person dying earlier than expected. Of course, the cause-specific mortality was high for cardiovascular disease and dementia. That is being found that those with osteoarthritis that has this problem, they are more prone to this disease and they die from it earlier than those who do not have osteoarthritis. And the more severe the working disability, the greater the risk of death. So this may be due to increased risks to low-grade systemic inflammation or lack of physical activity according to Okas et al. Similar result has been reported. But that leads us to the fact that 4.9% and 25% of the increased risk of all-cause and CVD mortality among women with hip OA could be explained by poor physical function because of this reduced mobility, and they are prone to, sudden death. However, in the Netherlands, they have different results. Why? Because they are active seeker of health professionals. So while they are being attended to for their osteoarthritis, other comorbidities are being treated. So they are not dying. The association between osteoarthritis and other comorbidity in terms of mortality rate is not is differ from what is reported in other clients. Osteoarthritis being managed with comorbidity, particularly the cardiovascular disease risk factor in that environment, has reduced the mortality rate amongst them. So therefore, it is advised that more attention should be paid to modifiable cardiovascular risk factors in this group of people, so that they don't, their condition doesn't get worse. The aggressive approach to reduce working disability must be embarked upon by physicians. And this can be done in conjunction with physiotherapy by using walking aids, rehabilitation program, and ultimately arthroplasty. So economic burden, these are some of the things that have been found out, that osteoarthritis remain a major public burden, with direct costs as of 2002 in France exceeding 1.6 billion euro. 1.7% of the expenses of the French, they account for 1.7% of the expenses in their health system. And medication costs about 570 million. And as of 1997, it accounts for $7.9 million. But by 2004, that has jumped to $22.6 million. So that was the increase is alarming. We don't know what it is now. Definitely it will be much more than this. The indirect cost of caregiver absenteeism was estimated to be $10.3 billion. The management of osteoarthritis can be non-surgical or surgical. And the goal of treatment is to decrease joint pain and stiffness, because that's the first thing that brought them to the hospital. You want to delay further progression of the disease, especially if they are presenting early enough. Improve mobility and function, increase patient quality of life. This is the aim of treatment. So the treatment regimen prescribed depend on many factors, which include the age of the patient, the way at which it's presenting, the overall health status of the patient, the activity, if it's a footballer, a pepper seller, or a farmer. So, and at the time they present, the severity of the condition at the time they present to the hospital. The non-surgical treatment, which is the conservative, is patient education. Is important to talk to the patient to know what is wrong, what can be done. The cooperation between the physician and the patient is very important, so that you can give instruction. If the patient needs to lose weight, do some exercises. I see people today do all manner of exercises, jumping around, and some of those exercises have been embarked upon as a result of ignorance. When you are above 40, I don't expect you to be jogging, and especially along the road that is not smooth. We encourage brisk walk. Activity modification may be necessary to reduce the rate of progression. Physical therapy, weight loss. Swimming, there are so many things you can do to lose weight. Knee braising to ease mobility, because you want to make sure the patient is moving. Medications are there. That includes intraarticular injection, steroid, and hyaluronic acid intraarticular injection. This hyaluronic acid is one of the components of cartilage and synovial fluid, and is very good when the patient presents early and the early or moderate stage of osteoarthritis. When you give, it can serve to cushion the joint and also stimulate the synovial membrane to start producing the natural synovial fluid. Surgical treatment includes this osteotomy. If it's affecting one compartment of the joint, one can do unicompartmental arthroplasty. For total arthroplasty, that is when the patient presents at the advanced stage. And the next picture I will show you will just tell you some of the patients that present in the University College Hospital that had total knee replacement. This is a 74-year-old woman, came to the hospital crying, could barely stand up or walk on her own, but we scheduled her for surgery. You can see the lateral picture. This is the X-ray of the woman. You can see all the feature mentioned earlier is present. The joints, one cannot even see it. The osteophytes, the subchondral sclerosis, subchondral cysts are all present. And this is the AP view. The joint is completely destroyed. And that is what is responsible for the varum deformity that she had. She was scheduled for surgery, and this is what she got thereafter. This is the lateral view. And this is the same woman. I remember after full rehabilitation, she offered to take me for shopping. That this is some of the things she's not been able to do, that I haven't done this, that you won't mind to. So that's to tell you the kind of relief she had after the surgery. So this is another one. This woman could barely stand more than 2 minutes. Again, this is the joint destroyed, and this after the surgery. This 72-year-old woman with hip osteoarthritis and had her joint replaced. So in conclusion, with aging of the population throughout the world, because it's a common phenomenon everywhere, the doctors, the physiotherapy, all the professionals, we must prepare for the large increase in the number of people with osteoarthritis requiring health services. So strategies, policies must be put in place to reduce the burden of hip and knee osteoarthritis through primary and secondary prevention, as this disease incident increase among the population. Thank you for listening.
Thank you very much, Dr. Omoyeni. You can have your seats. Our time is fast spent, so we are going straight on to the second lecture to be delivered by Dr. Adeshola Odoli, a consultant and specialist physiotherapy, specializing in orthopedic physiotherapy. Thank you, ma'am.
Thank you very much. I don't just want to stand on existing protocols. I think I want to sit for balance. I'm so delighted to make this presentation today. In fact, when Professor Elegbe reached out to me, sincerely speaking, God sees my heart, I was a bit hesitant. I didn't want to take up any webinar presentation because of the task and the load of this headship. I'm just new to the task, so it's a bit overwhelming for me. But after much consideration, thinking about the fact that it's about the professor, I don't guess we should not say elderly individuals. It's about the older adults. And because I've always had a passion for elderly individuals, because for every one of us, we don't know what old age has in store for us. We should always have compassion. We should always have empathy. We should always be interested in the elderly individuals. I just told myself, Adeshola, you have to go for it. Just take it up. And then we were supposed to have the presentation last week. So that was why I was hesitant. 3 days, 4 days preparation. But thank God that the webinar is on today. The topic of discourse is the burden of osteoarthritis in the older adults. But Dr. Omoyeni talked about this burden, but I will still talk about it. So I decided to bring up something in collaboration with Professor Elegbe because I asked her, I said, Ma, what exactly do you want me to speak on? So she now told me that she has 2 topics of interest or titles. So she sent the 2 titles to me, and my mind just, clicked with coping mechanisms in elderly individuals with osteoarthritis. Okay, so I have an outline, and then basically I'll just be setting the scene about my experience as it relates to the management of osteoarthritis. I will talk briefly. I'm not going to waste your time. I'm not going to burden you or bore you about talking about the burden of new OA. Then I will talk about living with it because, if you have OA, since there's no cure, you have to live with it. Then what are the coping mechanisms and the implementation strategies? Then I'm going to talk about some myths and facts about OA that will now lead us into talking about my area of specialty, regular exercise and physical activity. And again, I will be speaking through the lens of a researcher, a clinician, and an educator. So I will be talking about some of the studies that we have carried out and my experience as it relates to individuals with osteoarthritis. I will just be going on. If the slides let the slides not follow. Okay. So I have this classic presentation of a patient I saw many years ago. And I took the picture. For the physiotherapist here, I think I should acknowledge my colleagues, even though it is a medical and women association program. But we have physiotherapists online. And we have some of them here seated. Thank you for the support. I appreciate you. And if you look at this picture, I'm sure you know how the orthopedic unit of the physiotherapy department actually looks like. You can see the curtain. So I took this picture several years ago, and I can just imagine this mama, about 67-year-old mama. And like Dr. Moyeni talked about when she was talking about the presentation, I can just imagine that this mama already has maybe loss of articular cartilage or destruction. I can just imagine that the mama already has subchondral bone sclerosis. The mama already has bony spurs, osteophytes. There is narrowing of the joint space. And that there could even be varied rates of inflammation of the synovium, of the menisci. And basically, looking at all of this, we focus on the innate structures, most importantly, when we are talking about the presentation of osteoarthritis. Or even though the contractile structures, like Dr. Moyeni talked about, the muscles and the tendon could be affected. But basically, this is the presentation, and this is the mama that we managed several years ago. And when we managed Mama, then, I'm going to make a confession. Then, several years ago, when we practiced, most of us, most healthcare professionals, I think so, whether orthopedic surgeon, whether Professor Alonga is seated here or not, I will say what I think obtained several years ago. When our patients come to us, we have this Lord and Master kind of a thing. And in managing our patients, we often focus on impairments, things that are, pain. You have pain. Let me give you injection. You have joint stiffness. Let me see what I can do. You have muscle atrophy. Physiotherapist, let's strengthen the muscle. But sometimes we do not focus on what is important to the patient. And what is important to the patient is about function. Dr. Moyani talked about it. Functional limitations. Patients are concerned about what they couldn't do before and now what they're able to do. If a working function is limited or impaired, like you said, especially in the elderly, when they want to do a little bit of social, somebody is doing a ceremony, I have to just go. The daughter of that my friend has a wedding, and I think I should be there. So it is important that we focus. I'm just sharing experiences now, just setting the scene. That when we are managing our patients, let's hear their voice. Let them tell us what is important to them. And in telling us what is important to them, let us have instruments. Let's have scales. Let's have patient-centered questionnaires that borders on that particular function that the patient is concerned with. And if we cannot get such instruments, even though I don't want to be like they always say in their song that they will say somebody is bugaing. For several years ago, 1997 precisely, when I started my postgraduate program, that was when this interest in development of outcome measures, and Professor Longe, okay, I'm sure you remember vividly, sir. And there's this concept of developing something that is culture sensitive and environment friendly, that borders on what is important to the patient. A patient may be bothered about assuming the Islamic praying posture. You won't get that in anything, any instrument. A patient may be bothered about, making amala. Just want to make amala. And sitting on a low stool may be the problem. When we want to make our amala, is this modern days that you have cookers, that have, then you sit on the floor. Put your two legs in between the pot and you make the amala. So, and that takes me to the development of a tool that we developed, myself and some colleagues, very senior colleagues, several years ago, the Ibadan knee hip osteoarthritis outcome measure. So I'm using this opportunity to advertise that our products. Let all healthcare professionals, especially those living in Nigeria, let them get to use this in assessing the therapeutic effectiveness or the effectiveness of their interventions on patients. Okay, so how do we assess the burden of knee OA? Dr. Moyedi talked about some of these things. We want to assess in terms of morbidity, the burden, in terms of incidence, prevalence, quality of life, mortality. And one thing that strikes my heart that is of concern to me, disability adjusted life years. Because we are talking about persons living with disability. They come up with physical disability, and that is a great burden on individuals that have knee osteoarthritis. I want to crave your indulgence, Saz and Ma, that you allow me to focus on the most prevalent, the joint that is mostly affected with knee OA, because if I have to talk about everything this evening or this afternoon, we won't be able to touch what is of primary interest to me. So, Dr. Moshani already talked about the knee, with incidence data. We have data on prevalence, and we have hospital-based data estimates. But when Dr. Moshani was presenting, Dr. Moyeni, pardon me, Dr. Moyeni, you committed an error, but I will forgive you. The reference that you gave, you wrote Aderonke et al. It's Akikpelu et al. Because we were all part of, myself and Professor Longe, we are all part of that study. So when you were referencing it, I said, yes, this is what we have done in Nigeria. We've done community-based prevalence studies in the the southwestern part of Nigeria, northeastern part of Nigeria, and even in the southeastern part of Nigeria, because we found out then that most of the studies, prevalence studies, are hospital-based, nothing in the community, and that is what we need. And in UCH, several years ago, we also found out that the NEOA accounted for 6.4% of all new referrals. I won't repeat this. This is a repetition of what Dr. Omoyeni talked about. It's about the research that we have conducted. We've conducted several studies that borders on the prevalence of NEOA. This is another study that we also did. It was talking about functional limitation. We found out from one of our studies again that in terms of functional limitation, which is a primary thing, they had difficulty with kneeling, squatting, climbing stairs, walking, sitting on low stool, prolonged sitting, and even coitus. And it is something that is important too. Also, there is a great impact on quality of life. He mentioned that too when he was talking about the impact of OA on quality of life. And yes, the global burden as it relates to DELIs, disability adjusted life years, disability plays a major role. There is no way that you are going to effectively
So if I can, if somebody can ascertain everything. I'll let you know. Yes. I'm doing both, so
Okay, thank you. Apologies once again for the break in transmission. I was just talking about disability adjusted life years and the fact that disability plays a major role in determining the overall status of a population, even starting from taking individual statistics when we manage our patients. And there are two summary measures of population health. So if you are talking about a population and you do not give consideration, you are talking about a population health, and you do not give consideration to disability, then you are joking. So we talk about disability adjusted life years and healthy life expectancy. And the traditional methods of population health have always focused on mortality. Just talk about mortality. Disability is one key measure of population health that we should also focus on. In calculating disability adjusted life years, I won't bore us. I just want us to take just one thing from that it is equals to the years lived, the years of life lost, okay? That is YLL, plus the LD years of life lost because of disability. That is YLD. So if we are talking about disability adjusted life years, these two concepts must be taken into consideration. Next slide, please. This is just how to calculate it. When you say somebody has a 1 daily, we are talking about loss of 1 healthy year of life. Assuming that the individual is supposed to live elderly, but because of disability, the person has lost one healthy year of life. Please, and you can just imagine, with all of the information that Dr. Moyeni gave us, And because of all of the things that I listed, talking about the burden in terms of mortality, incidence, prevalence, economic cause, disability, I'm sure you quite agree with me that when we talk about osteoarthritis, especially of the knee, is actually a burden. You can see what is happening there. All of those things that Dr. Omoyeni talked about in terms of the features, if this vehicle were to be a human being, there will be pain, there will be, there will be stiffness, there will be muscle atrophy. There is already subchondral bone sclerosis. There's already cysts, subchondral cyst formation. So it is very, very, I want to thank the organizers again that this issue of osteoarthritis is a burden that we must all give consideration to. So now, I'm sure you agree with it that it's a great burden. Yes or no? Yes. Thank you. So if an individual has the features, has been clinically diagnosed with OA, using the ACR criteria, maybe just looking at the history taken, an examination, physical examination, you can make a diagnosis of OA. Or if you want to look at history taken, physical examination and radiographic evidence, you can make a diagnosis of OA. Or if you want to look at history taken, physical examination, radiological investigations, and laboratory investigations, you can make diagnosis of OA. Yes, I have OA. Whether it is severe, whether it is mild, severity, or whatever, the OA is there. There is pain, there's physical disability, there's interference in activities of daily living, whether instrumental activities of daily living or basic activities of daily living. And of course, there's a reduction in health-related quality of life, and there is no cure. What should I do? I will live my life. So I have to live with it. And in living with OA, and because life is meant to be lived, if you must live, that means you want to have both quantity of life and quality. So I want to live long, and I want to live in good health. So quality and quantity of life. So what do? I would have to cope. I will map out strategies. All the stress that we are going through in Nigeria presently, we are living. You cope. Map out strategies. Life must continue. In as much as the giver of life, the source of life, God, has given us that life, we must go on with it. So, basically, in the coping mechanisms that I want to focus on, it's not just about physiotherapy, because I am passionate about the patient. I'm passionate about the person. If I'm going to, talking about an educator, I'm passionate about my patients, about my students. So talking about the elderly individuals that we are talking about, that osteoarthritis, I'm passionate about elderly individuals. So because of this passion, I want all of these people to be partners in their management. Gone are those days that it is the doctor, it's the physiotherapist, you are the oga, whatever you say, you scribble something, the patient cannot decipher, the patient does not know what you have written. Gone are those days. Patients are being empowered to be partners in their own management. That's the paradigm shift. They must be empowered. You must tell them what is wrong with them. When they have their CT done or they have their X-ray, tell them what is on the X-ray. You didn't pay for them. They paid for that X-ray. We should not hide the X-ray and put them in the corners of our offices. We should give them information. This is what has happened. As it is, this is it, these are the bony spurs and everything. There is no cure, but we can manage it in such a way that we will prevent the acceleration of the disease. And that is what we are talking about, self-management strategies. Patients, clients, individuals as partners in their management. So we have different pain coping strategies because we want you to be able to cope. The pain is there, but we want you to cope and live with it. Cognitive strategies and behavioral strategies. I will not lay emphasis on that, but I just want to bring that to fore because when we are talking about healthcare providers, the clinical psychologist has a role to play. Has a role to play in the management of individuals with OA. Because if you look at all of the list, ignoring the pain, distancing from the pain, distraction, all these are cognitive strategies, catastrophizing, you know, when the individual feels that there is a magnification of that pain. I just feel that don't touch my knee, don't touch it. There is this sense of magnification. And of course, strategies. People believe in prayer. I believe in prayer too, and I believe it works. Your faith, your prayer is also a form of coping strategies. Behavioral strategies, increasing activity levels, increasing pay behaviors, all of these components. I will break some of these things down on how you can implement these strategies as it relates to your emotional well-being, or talking about health-related quality of life. We have so many domains. We have the emotional domain, we have the psychological domain, we have the physical domain, we have the social domain. So I'll be talking about how you can implement all of this as an individual that has to live with osteoarthritis, and you need to cope with it. Emotional, there is something about life, positive attitude. When you analyze the situation, and because the patient is knowledgeable, a knowledgeable patient, a knowledgeable individual, a knowledgeable older adult is an empowered person. And that individual will also help you, because at the end of the day, the frequency of visits to your clinic will also be reduced, because the individual knows the do's and don'ts. The individual knows that, oh, this is what is happening to me. So, and because of that, because you have laid out all of the information to the client, the patient has a positive attitude. But one thing I would want to advocate for, don't just focus on the things you cannot do. If, for instance, an individual with knee OA cannot walk for more than 5 minutes, even if it is that 2 minutes that you can walk, make a list of it. Focus on that. Like in physiotherapy, when we manage our patients, we say a flicker of contraction is all we need to work on. When a patient has a flicker of contraction, that flicker of contraction will move to power 2, from power 2 to power 3, from 3 to 4, and before you know it, using the manual muscle testing, Oxford muscle grading, it is 5. So the little that you can do, make a list of it. Please, talking about our emotional well-being, because we know that the disabling effect of OA can be overwhelming. Like Dr. Moyeni said, it can be very overwhelming on the person that has OA. But you can decide to take time out for leisure activities. When I was looking at Professor Elegbe's DP, I saw this picture of a garden. And I was just wondering that, Ma, do you have a garden? Because when I saw the picture, I said, Abi, Mama has a garden. So if you have a garden, if it is something that you love doing, or you have flower pots, enjoy it. Take time out to do what you enjoy doing. If it is knitting, if it is listening to music, listen to your music, even if it is home alone. And if it is dancing, if it is attending prayer meetings, even if it is online, thank God for, for virtual everything. You can, watching a movie, if it is making meals, I want to make this special egusi, whatever. That is what I know how to do best. Do it. If you know how to garden, do it. Another thing that can help you emotionally to cope with osteoarthritis is taking care of yourself. You have to love yourself first, sincerely speaking. Most of the times we do, even I, sometimes when I get to the office, I love the demands of the work more than myself, and I'm speaking to myself too. We have to love ourselves first. Take care of yourself, pamper yourself. For the elderly individuals that are females, even males, you can go for pedicure. It's not just about the female alone. Go for manicure, go for your haircuts. If you want to go for massage, let them do everything from head to toe and just enjoy yourself. You can go on short vacations outside your natural habitat. Just go, even if it's just 1 week. If you love having a journal, you can be keeping short notes, you know. And if it's one thing that I found out from my mom now. They do this BC thing, broadcast messages, everything, they'll just be forwarded. And before you know it, you have up to 30. And meanwhile, I've seen some of these messages, I've read them over and over again. But if they enjoy doing it, let them send us the BCs, send us short notes. And that is about the emotional. So talking about the physical, please, comply with your treatment plan. Whatever your physician has told you, I don't want to go to orthopedic surgeon because it is when it is very severe and it is affecting your function and it's becoming disabling, most of the time, people don't report. But when it becomes disabling, that is when they come, and of course, maybe at that time, physiotherapy will not work. You have to go and do your arthroplasty, the joint replacement. Then again, physically, you can assess whatever is being given to you. Like I said earlier on, when you have tools, there are pen and paper instruments. Somebody has treated you for 2 months. As the individual with OA, you can assess the effectiveness of that intervention. For instance, if the tool has a maximum score of 30, and what you can do from all of those physical functional activities that you have in the questionnaire, you can only get 12 over 40. At least that will spur you on. You want to set goals. I want to improve. In the next 1 month, I want my score to improve from 10 to 15. And before you know it, some of those things that you think you cannot do, when you comply with your treatment plans or what your physician, your physiotherapist have told you, you'll be able to get better outcomes. And you set realistic goals for yourself. You know you cannot walk for more than 5 minutes without feeling the pain. So please, when you want to set the goals, don't say, Dr. Odole said, I should start. You will set, okay, for 5 minutes, let me move to 7 minutes. You know, don't allow anybody. You know you are empowered, you are knowledgeable. You know the risk factors. You know that there are modifiable and there are non-modifiable risk factors. The ones that you can prevent, you don't want to have an injury with the OA, because we know that even for younger people, previous injury is a predisposing factor, is a risk factor to having OA. So, biomechanical intervention, use assistive devices, your cane, cushioned heels. Sometimes you may need to have cushioned heels. For instance, for me, I have pest planners. I like to put on something that maybe because I'm very tall, so most of the times I always want to wear something, but you can never find me putting on pencil. You won't. You won't. So you should have, you can have wedges depending on the compartment that is affected, whether the medial or the lateral compartment, whether you will need to do a medial wedge or a lateral wedge. Let them put it in your shoes. It does not matter. You are the one that you want to live long. You want to live long and well. Quality and quantity of life. Knee braces, shoe inserts, all of these things are important. And they are coping mechanisms physically. Then again, even at home, you could have, you can just buy these topical non-steroidal anti-inflammatory medications. Massage, those are, I'm talking about self-management. Things that you can do on your own and you can cope since you have to live with this disease. Then we have transcutaneous electrical nerve stimulator. We have it on the counter. People buy it over the counter. You can buy it and get your physiotherapy, or even reading through the manual. And if you're not clear about how to use it, you can get in touch with the physiotherapist, let them teach you. You can have all of these things on to manage yourself. The next slide. Physical. Professor Alonga talked about, he said something about adaptations. Even though I said home, he said something about the kind of seats that we have here. We can adapt the seats. We can do it in such a way that, because for elderly individuals, they need support. And because they have been sitting, even these seats should be in such a way that you don't have to necessarily bend your knees to 90 degrees of flexion. So you can modify all of those seats. So that when, and you have support, you have armrest, yes. So that when the person wants to stand with the armrest, it is because we are talking about independence. We want them to be as near independent in carrying out activities of daily living as possible. Please, if you can afford it, sincerely speaking, for the elderly individuals with For the older adults with knee osteoarthritis, if you can get a housekeeper, get somebody. Even though that is not a gateway for sedentary lifestyle. It is not a gateway. So you can get a housekeeper, eat elderly, and if, like Dr. Moyeni, I keep referring to you because you said a lot of things. If your BMI is greater than 30 and you feel that, yes, this is obesity, or it is between 25 to less than 30, you are overweight, please, if you need to have a weight loss, it's important because you are also protecting your joint. Please sleep well. Have very good sleep environment. You know, some people, I don't want to talk so much. When their sleep environment, books on the bed, asho, everything, have a good sleep environment. If you love flowers, put it there. If you like candles, scented candle, put it there. It is for yourself. Don't forget we are talking about quality and quantity of life. Please refuse a sedentary lifestyle. Don't allow those children to overpamper you. Grandma, don't worry. I will go and get it for you. Let me go and get water for washing hands. Please, if you can do all of these things yourself, please, don't allow them to do all of those little things for you. Stand up yourself. Go to the kitchen. Wash your hand. Go to the dining. You know, all of those things are important. Before I talk about regular exercise, because that's the key thing as it relates to my profession, there are some myths that I want us to disabuse our minds of. There is this myth that more pain causes more damage. That, if you have so much pain, hey, that means that the person has more structural damage. No, not necessarily so. Because evidence has also shown through research that there is no correlation between radiographic evidence and even the clinical symptoms and signs of osteoarthritis. So because experiencing pain is a complex thing. There are so many things that talk about our pain experience, our moods, our, the psychosocial indicators, the yellow flags, all of those things are there, fatigue, level of activity, all of this. So you cannot necessarily say that because you have so much pain, there is so much damage. Just leave that leg. There is so much. No, that is a myth. And another myth is that OA is just about wear and tear. Everything about OA is wear and tear and bone on bone. No, not necessarily. When we talk about osteoarthritis, we are actually talking about when the articular cartilage cannot even repair itself. Because we have younger people that have OA. And all of those factors that Dr. Moyeni listed, there are so many things that does not, even though being older is a very strong predisposing factor to having osteoarthritis, but it is not necessarily wear and tear or bone on bone. So there shouldn't be any fear that, hey, because I have pain, I don't want to move it. I don't want to move my joint. And when you do that, when you don't move the joints, what happens? There will be stiffness. When there is stiffness, there will be reduction in whatever you're going to do. When you have that, you have atrophy. And before you know it, reduction in quality of life and reduction in quantity of life. Okay? The other myth is that exercise will damage my joints further. The opposite is true. Exercise and movement are the safest and the best defense against osteoarthritis. They act as joint lubricants. We need our joints to be well lubricated so that we keep moving. The other myth is that no matter what I do, just leave me. It is cuckoo there. Maybe they have told me that there is no cure. No matter what I do, my OA will only get worse. No. There are so many things that you can do that would help you to be able to manage the pain. Dr. Moyeni, even though Dr. Moyeni, you said something, please. In terms of prescription of exercise, please, I want you to focus on orthopedic surgery. Just leave that to us. Just leave the issue of exercise prescription, leave them to us, because we have to give prescription as it relates to that individual, the age of the individual, the comorbidities. So it is not just about we advocate that they should do this. We also want to test their ease of fatigability. We are talking about older adults. So when you are making your reference to us in physiotherapy, just give us the diagnosis. Leave everything to us. Your patients are in good hands. Thank you. So now let's talk about regular exercise and physical activity. Like I said, see your physiotherapist for exercise prescription. That is the best thing. We will tell you what to do. How best you will not stress, your joints. How best you'll be able to cope with the osteoarthritis. Because exercise is medicine. If you look at all of these benefits of exercise, I'm sure you would agree with me that if exercise can decrease pain, if exercise can increase physical function and ability to perform activities that matter to you, if exercise can increase muscle strength, can limit joint stiffness, can increase balance, and reduce risk of falls, increase your energy level, and decrease feelings of tiredness, maintain a healthy weight, boost your mood, increase your cardiovascular fitness, help you sleep better. What else do you want to live long and have quality and quantity of life? Exercise is medicine. Social, I will be rounding up very shortly. Social, spend time with friends and families. You know those that are your friends. Spend time with them. Join support groups. I don't know if we have osteoarthritis support group in MWAN. If we do not have, we can start something like that. Support groups for individuals that have osteoarthritis. Then, please, you need to talk to your healthcare professionals. I don't know the blend of individuals online, but if you think you are having pain, you are having limitations in function, please see your healthcare professionals, physiotherapists, physician, orthopedic surgeon, see them. Finally, I'm ending now. She gave me 2 minutes. Finally, beyond all of these things, you know your body much more than any other person. It is what you tell us as healthcare professionals that we work on. So if you don't tell us everything, somehow we may be able to decipher people that are malingering by the time we carry out some tests, lab tests and all of this stuff. But listen to your body. If you recognize any triggering factor, please don't hesitate to tell your healthcare professionals. If there are comorbidities, please recognize them so that all of these things will be put into perspective when you are going to be managed by your physician, your physiotherapist, the orthopedic surgeon. If you need help, please ask for help. And of course, the last but not the least, your faith. It is still about God. Please pardon me if there's anybody that does not believe in God. It is still about God because God is the source of that life. That life, we are saying quantity and quality of. It is God that owns it. So we still need to have a kind of a relationship with that God so that will be able to help us to be able to cope with this joint disorder. Professor Longe again told me several years ago that the knee joint in itself is an organ. So when there is a problem with that organ, what would you expect? And on this note, I want to thank you very much for your attention. Thank you.
Thank you very much. Those of us who are here, please can we give another round of applause for our 2 resource persons, Dr. Richard Omayeni and Dr. Adeshola Odoli. I believe the chairman of the occasion is online, and she will want to continue to direct the affairs of this webinar. Thank you.
By health. I hope you are hearing me.
Yes, ma'am.
Yes, okay, thank you. Because health has been defined to cover all these areas. I don't think that I need to spend a lot of time summarizing what they have said. But just to say that what they have illustrated, what they have actually established for us is that taking care of this problem or this disease requires collaborative effort. Not only do you need a surgeon, but you need a physiotherapist. And I must say, you need the patient herself to be able to accept the kind of education you are giving her. I don't know whether I missed this, but there was part of the presentation which our dear physiotherapist, Dr. Odeli, was supposed to have told us. That is about myths. Maybe she did. I might have missed it. Maybe that was when we were having technical problems. But what we know with diseases like osteoarthritis and chronic ailments like that is that it leaves room for patients to start shopping around. They go to various places and, just to say that, well, you are not, they want immediate relief, unfortunately. And I believe that when we are talking to them, we need to bring this to their notice that there's not going to be immediate relief. It is going to be slow but steady, and it depends on them. A lot of these manipulations, etc., will depend on them, how they accept what you have told them, and how they practice what you have told them. And I always also believe that when you see these patients, you should see them with the members of their family, if they can come with them. It helps a lot if you know that there are some members of the family that can assist them in carrying out some of the advice, not necessarily instructions, but advice to them. Without the support of the family, they may actually not be able to benefit from the consultation with you. So this is one thing that I feel we need to emphasize more. The fact that getting better is a collective, is by collective effort of the family. Our orthopedic surgeon has said that we are dealing with a disease of extreme ages, both pediatrics and geriatrics, I would say. That brings me, that reminds me of a story with my husband, who was an orthopedic surgeon. I, as a pediatrician, I believed sincerely in using methods that can be used at home to help children get better. And there was the time when we were trying to talk about oral rehydration therapy. Oral rehydration therapy was proven to be very good to help diarrhea disease in children. Of course, we had these young children, and one of them had diarrhea, and I said, hey, we are going to give her salt and salt sugar solution, etc. And my husband went berserk and said, salt sugar solution? No, you cannot do that. I said, but this is what we have studied, simple things first. So I'm saying this because I know that Dr. Omoyeni has told us about surgery, but luckily, he has also imbibed the doctrine of non-surgical methods. This has taken some time to come, It was, it's not long ago when the surgeons were very fast in taking you to the table and, wanting to cut. So I'm very happy that over time, even surgeons have agreed that non-surgical methods can work better. Having said all this, I'm not going to keep you longer because my dear seniors have sat for too long already, and they may find it very difficult to get up from their seats, just as I may find it difficult to get up from my seat. Let me just say that my seniors, it doesn't take long for us to catch up with you. The age gap is narrowing in terms of diseases. So the younger ones, please take note. This is what happens when you're getting old. You don't want to be held down for too long. So without much ado, I want to thank everybody. I want to thank first our president for dreaming and making this occasion come true. And I want to thank her entire team for helping her to bring the occasion to reality, to fruition. I want to thank the presenters, thank all the participants, and all my junior sisters there who have managed to come to listen, and they want their certificates, or what is CME. Yes, you do need your CMEs so that you know that you spent your time gainfully. And I'd like to say that one thing that I still have to emphasize is about our celebrant, how empathetic she has been, how to me, she shows a great interest in younger people. So today is a good day for us to celebrate her, that all of us are here to celebrate her. And we wish her long life, free from pain, free from regrets, free from anything that may cause her unhappiness, because she's blessed. She's blessed with very good children, grandchildren, and great-grandchild. So we thank the Lord for blessing her in this way. Then let me end by a quote, giving you a quote from Maya Angelou, who is another African-American. And she says, "My mission in life is not merely to survive, but to thrive, and to do so with some passion, some compassion, some humor, and some style." You should obviously add today that we also would like our mission in life to be free from all ailments of old age, including osteoarthritis. So thank you very much indeed for making you your chairman for today. I don't think that I really deserve it, because I'm way away from you, long way away from you. But I am so happy that the president has deemed it fit to ask me to be chairman. Thank you very much.
Thank you very much, Mama, Professor Adenike Grant, for the addition and sharing experiences with us. We have to go to the question and answer session, but before we do that, we have the head of department of the geriatric unit in person of Dr. Olowo Okere. And he was supposed to give us a goodwill message. And he's also a physician that manages the elderly patient who had osteoarthritis. Dr. Olowokiri, you are welcome. Thank you. Yes, please come and give the goodwill.
Permit me to stand on the existing protocol so that I don't breach protocol. But let me recognize the older persons, very importantly, the chairman of this occasion, Professor Adenike Grinch, and Mama. I noticed that the older people in the women's circle, they have a forum. Prof, what is happening to the ones in the men's circle? Because I've never seen it. And they keep on inviting the older. I've had the privilege of speaking among them. They will be inviting the older men to be part of them. But maybe Prof will look into that. So, Mama, I want to appreciate you, the national coordinator, the senior members forum. God bless you, man. That's Professor Eniola Elegbe. And let me also appreciate our national president. I've received so many calls from her. She will talk. The voice always looks like a young woman anytime she's talking to you. Professor Otolorin, God bless you. Dr. Otolorin, God bless you, man. And my Oga, let me say one thing. Anywhere we go in the part of this globe, we always say that Nigeria, geriatric medicine wouldn't have been known the way it's known today if not the efforts of Professor Temitope Alongo. And I'm always proud to say this. Myself and Abdebusoye, it's courtesy of him. He's the one that single-handedly ensured that we're trained as geriatricians. And by the grace of God, through his effort, many other centers are coming up. Of course, we want them to be better than our own. Oyo State, sir, they said they've changed from that place to another smaller place. You have to talk to them, sir. But I'm not interested in that one. But I know you can talk to the governor, and I don't know why they moved it, but nevertheless, the point I'm making is that Oyo State has approved geriatric center, and they has made a lot of effort in that regard. Osun State has already established their own. We wrote the proposal for them, and the Jesha people is bigger than our own, and that's actually the prayer. They came here, the model, Lut was here, Bini was here, just name it, everybody across. Akoko, thank you, sir. Okakoko, just name it, from all over, including from the US. They came from the US, all over, just to come and see the model. In Abuja, in the federal ministry, it is regarded as Ibadan model. And so that means that people will build on this effort of this man that is seated here. So, sir, we appreciate you once again. Let me now quickly round up by appreciating the MWAN for this wonderful opportunity, and especially this SME that is being organized regularly. I've connected online because of this crisis. I couldn't come on time, so I waited until the whole thing subsided. In fact, the road is still blocked. They just leave a small place, and you have to put leave before you're allowed to pass. And so once again, Ma, I want to sincerely appreciate you and your team and everybody for this wonderful opportunity. And please, always use the word older person. Elderly is discriminatory. I've seen it in your flyer. The word elderly is ageism. And so we tend to avoid it. People feel one kind when you say you are an elderly person. But when you say you are an older person or older adult, they feel comfortable. So you can use either of the two. I was reviewing a journal, one for some international people they sent to us. That person was using elderly all through. And I asked the person to correct it. Of course, by the time they sent it back, he has corrected some of those terminologies. So I want to once again appreciate you. Thank you very much. And let me also say that I have completed my 4-year term. And so my colleague, Dr. Adebusoye, he ensured that the geriatricians will do that place for some time on the takes his foot. It's going to be 11 years this year. And I want to say that God has helped us to be known all over the world. And it's just this small effort. And let me also appreciate every other person, the physiotherapist, the dietitian, the nurses, the psychologists, the social workers, the dentists, the lab scientists, and who else are working with us? The medical record. Next week I'll be in Britain. I'll be talking about, they want me to share in that conference, I'll be sharing how we were able to break barriers between interprofessional people. We know we have that challenge in Nigeria and they recognize it over there. But how did we work together to be achieving what we're achieving? And some of those things I'll be sharing with them next week. Thank you very much, my God bless you.
Thank you very much, Dr. Olowo-Okere, our host for this webinar. You're also our host, apart from Mama Elegbe. Madam MP, our national president, Dr. Adekemi Otolorin, has directed Dr. Temitope Ilori, a physician, a community physician, consultant community physician. We handle the Q&A online, while how we handle the one physical. But before I hand over the microphone, I want to recognize my teacher, my mentor, and also the foundation president of Society for the Study of Pain in Nigeria, Professor Olaiton Shoyonwu. You remember that pain has been repeatedly mentioned at this webinar. So she's online, and I want her to share experiences with us. I recognize all medical women online, the immediate national president, Dr. Oseji, the national president-elect, Professor Rosemary Ogo, all the state presidents of National Medical Women Association of Nigeria, the president of ICOMA worldwide, Professor Emmanuel Otolorin, and the husband of our national president. I recognize you all. So, Mama Shoyonwu, I want you to share your experience with us. Thank you. And Dr. Temitope Ilori, kindly handle the questions that have been posted on the chat box. Thank you.
Hello?
We can hear you.
Oh, good afternoon, dear mamas and eminent panelists. Congratulations, everybody. I'm sorry I couldn't be with you, but I congratulate my dear friend, Professor Eniola, Elebbe, the coordinator, and Dr. Mrs. Kemi Otolorin, my darling Abru. Experience-wise, I'm sure most of what they have said, the Society for the Study of Pain will endorse. And I remember that Professor Temitope Alonge, also a member of the Society for the Study of Pain, was the first person that was our ambassador to Abuja to talk about pain for the society. And thank you very much for being there again today for the Medical Women's Association. It's been a long journey, and I happy to say that we have a multidisciplinary group in that society. And we have been going on annual conferences for over 20 years. And currently, Professor Akinpelu, Ronke Akinpelu, is the current president, because the presidency of the society has been changing. And we address all forms of pains in a multidisciplinary way. So my little comment online was to say that pain is something that is subjective, and it is only the sufferer that can say how bad it is. And we must believe and treat accordingly. I'm happy that our Mama, Professor Mrs. Oduton, the darling wife of my mentor and teacher, Professor Oduton, has already told us that the issue of pain management is not just medications alone. It has to be both drugs and non-drugs. And these days, the role of the individual and family are being stressed, and it's very, very important. And that is the same thing that the experience that we have. And our society, we have both clinicians, and also physiotherapists, nutritionists, basic medical scientists, neurologists, a lot of professionals working collaboratively for pain management. And of course, the pharmacists have played a big role, because we also need, in some cases, maybe not in arthritis, but in a lot of acute cases, they have helped us to make sure that we now have opioid analgesics in the country. Thank you very much for this beautiful afternoon, and congratulations to everybody. Thank you very much.
Thank you very much, one of our elders, Medical Women Association of Nigeria. Dr. Temitope Lori is online, and she supports Medical Women Association continuing medical education. Dr. Lori, are you there?
Hello. Good afternoon, everyone. Thank you. I don't know if you can hear me. This is Temitope Lori. Yeah, this is Dr. Temitope Lori speaking. You agree with me, we've had a very educative and enlightening afternoon from our erudite presenters. We appreciate them once more. I think we have very few questions on the chat box. One pertinent question talks about, is asking a question: if all osteoarthritis, irrespective of grades, need to be referred to the physiotherapist upon review by the physician. That is one question. I don't know if Dr. Moyeni will take that. And then there's another question that talks about what has been your experience in the use of telemedicine in the diagnosis, follow-up, and management of patients with OA. What are the benefits, the challenges, and the recommendations? I don't know if my sister, Dr. Odele, would want to respond to that question. I think those are the two questions I've been able to identify on the chat box. Of course, there have been lots of comments appreciating the presentations. So thank you.
Excuse me, may I draw your attention to the fact that there are two hands put up? Maybe they want.
Oh, sorry about that. Thank you so much, ma'am. Yes, I can see Professor Moduko Nodekoma. You have the floor. You can ask your question, ma'am.
Yes, please. Thank you very much. I stand on existing protocol, and I want to appreciate all the presenters. And of course, I must recognize darling mother, auntie, Professor Olurin, Professor Oyin Olurin, and I sent her my warmest greetings to Professor Elebute and her family. I thank all the coordinators of this program that in spite of all odds and all the hiccups earlier, we are able to really come up with enlightening and educative program. I appreciate Professor Alunge. He has played a major role and personally and also in helping my widows. I must mention that, I take opportunity to mention that here. And I thank my doctor, Dr. Lowo Okere. Now, my question is this. I have osteoarthritis, but in Jesus' name, I'm going to be healed. And quite honestly, it's quite crippling. My children think I should go for knee replacement, but I do not want to. They said I should use walking stick, and I don't like it. I find it embarrassing at 79 to be using walking stick when my grandmother was erect. And Professor Soluna is still erect and walking straight at 89. Congratulations, ma'am. So please tell me, I didn't really get it. What kind of physiotherapy exercises that I should do? I didn't quite get that, please. I need that. I heard that I could do slow walking exercise from Dr. Moyen. But please, I want to ask Dr. Dele, what do you recommend? Thank you. God bless us all.
Thank you very much, Ma. I'm sure Dr. Dele will respond to that question in due time. Thank you, Ma. I can see Mrs. Onyebuchi Oko. Please, you have the floor.
Oh, thank you, the presenters, for a
sorry,
job
good to have a man in the house.
Thank you. I'm not a woman, I'm a man.
Glad to have you around, sir. Sorry about that.
All right. Actually, my question, I placed it on the platform, but it wasn't mentioned. My question is centered on the knee brace that was talked about. How often a patient that has osteoarthritis, do we encourage constant wearing of the knee brace? Or is there a certain stage where the person would have reached a treatment we say, okay, we discourage the wearing of knee brace for a patient that have osteoarthritis of the knee?
Thank you for the question, sir. Dr. Dele, please note that. And there's another question that says, can glucosamine capsules be given to the elderly with OA? I think it wants Dr. Omoyeni to respond to that. Can glucosamine capsules be given to, well, they say we should not say elderly, older persons with OA. And somebody's asking if water aerobic is helpful in managing arthritis. Water aerobics. I think Dr. Odole would help us out with that. So I think we can take the responses for now. Thank you all. Our dear presenters would like to hear from you regarding these questions, please.
Oh, okay. Thank you for those questions. I will just respond to them quickly. The first one says that should all patients with osteoarthritis should they be referred to physiotherapy? I did mention during my presentation that treating a patient with osteoarthritis is multidisciplinary approach. So at every stage, they have to be involved. Whether you are managing them conservatively or surgically, pre-surgery, they are important. But more importantly, after the surgery, you know, ambulatory training, muscles, cortical training exercises, they also do all that. So we work with concerted efforts to ensure optimal outcome in those patients. So yes, they should be informed from beginning, irrespective of the stage of the osteoarthritis. The other one, the glucosamine capsule. Glucosamine and chondroitin are part of the cartilage and articular cartilage. So some studies have shown that there could be some benefit when you take them. There's nothing wrong, there's no side effect. So that could enhance the repair of the articular cartilage if it's taken appropriately. The other thing I would like to mention is, I said it when I was presenting the hyaluronic acid. I'd be found that if a patient presents early and is given, it can delay a patient that would have had total joint replacement. It can help delay the progression of the disease and improve joint function. And that is an alternative treatment for a mommy that asked question that she doesn't want anything, but she doesn't want surgery, even though she has been counseled to go for surgery. So, she can have intra-articular injection of hyaluronic acid. That can help her to a large extent. I think the other ones are for my sister. Thank you.
Thank you. Thank you for those questions. The first one about telemedicine. Well, I will talk about telephysiotherapy because I know that we have done, incidentally, we've done some studies that borders on telecoaching, telemonitoring. So it is something that is feasible. It is something that is doable. If somebody had told us 10 years ago that we'll be having e-learning, we wouldn't have believed it. Now we are talking about managing our patients from a distance. And Professor Alonga is still going to talk about that because I remember too, the telemedicine unit that we have in the UCH, was actually it was an initiative of Professor Alonga. So telemedicine, when we talk about medicine, it is not just about providing medications. It's not about surgery, education. When you are able to give your education to your clients at a distance, it is still a form of you, because anything that you have to do at a distance, whether you store the information, you forward the data, is a form of telemedicine approach. Whether you see your patient synchronously through video conferencing, or whether it is still a form of, telemedicine. Whether you send the X-ray, I remember then we're having so many education programs then. Whether you project the X-ray of your clients, through a screen, and an expert is somewhere in a telemedicine hub and is seeing that radiograph and making assessments, it is telemedicine. So it is something that is doable. We know that we have our challenges. We may not be able to start the high-tech thing, high-fidelity kind of thing, but the little that we can do. I remember when I talked about this issue of telephysiotherapy there, some people said, Odole Otunde, it is what everybody is not talking about that you want to talk about, several years ago. And in our own little way, we just did something very simple. And it's about assessing the outcomes of pain and physical function in individuals that have knee osteoarthritis. Something very basic. We had our patients come to the clinic for baseline assessments. We had structured exercises that we gave them, in addition to the conventional physiotherapy. So we took our baseline assessments, then subsequent visits, we had two groups, the control group and the experimental group, the ones that we wanted to be seeing from a distance, wanted to be managing or monitoring the exercises from a distance. And the groups, they were assigned, randomly into the two groups. The ones that were not coming to the clinic stayed in the comfort of their homes. And we were managing them, we were, monitoring them to be sure that they were carrying out those structured exercises. And at the end of the day, we found out that they were comparable. Both groups were comparable in the outcomes of pain, physical function, and quality of life. Even though there were challenges, we had challenges of ethical considerations, confidentiality. When we did another study about barriers to the uptake of telephysiotherapy in Nigeria, there were some challenges that were raised. Confidentiality, ethical issue. The issue of money. Since UCH was telling us then that you should make money, generate IGR, when you leave them at home, when you leave them at home and the frequency of visits reduces, how would you generate the money for UCH? So there could be some barriers, but like I always say, I believe that whatever, the journey of 1,000 miles starts with a few steps. Let's just start that few steps. Let's even do as basic as having an Android phone, monitoring them. During COVID, we were managing patients with WhatsApp. Mama, do your exercises. Is your daughter there? On WhatsApp, put video on. Let's see what you are doing. Are you doing it well? We were able to do some things, even though it may not be as, we will not get desirable outcomes as much as when you see them, especially when you need invasive techniques. But even invasive techniques now, so many methods of doing invasive techniques. So I think it is doable. Telemedicine, telephysiotherapy, very doable in our own little way. Then the types of exercises, when we talk about interventions, there is this evidence-based practice. And most of the times, when we talk about judicious use of evidence from research, based on the physicians, including the physician expertise and patients' preferences and values, that is what evidence-based practice encapsulates. But even then, most of these evidence that we generate are through randomized control trials. And for randomized control trials, we have these strict things that you must do: inclusion criteria, exclusion criteria. The RCTs somehow do not reflect real-world states, real-world scenarios. So I want to go to the exercises. Evidence has shown that aerobic and strengthening exercises, when you are talking about the first line of action, has very strong evidence. Aerobic exercises, it could be walking, I don't know, it could be cycling, but elderly individuals, I don't know if you have been swimming or dancing, thank you, sir, and swimming. If you have been swimming from your young, till you can swim, you can include them swimming. So aerobic exercises, strengthening exercises, very, very perfect in terms of improvements in physical function, improvements in quality of life, and reduction in pain. Then the knee brace, yes. Evidence has inconclusive, research has inconclusive evidence with the use of knee brace. But I tell people, real world scenario, we've had patients that will tell you that when I use that knee brace, and I'm even better. And because I actually feel that many of us in the laboratories, that is in the clinic, we don't churn out what we have in terms of real world data. We do not churn out what we have. We only talk about RCTs all the time. Then, what's the other? I think that is all. Knee brace, okay? So knee brace, it is not all the time. Just like I would not advocate for somebody to put on spinal jacket or whatever all the time, support. Because we're also talking about strengthening your muscles. So, for instance, if it is not all the time, if you are at home, just doing your daily activities, you don't have to walk long distances. But if you have to walk long distances, you may just use it to support for that period. And as soon as you get to where you are, remove it. Do your exercises. Do your strengthening exercises. We do not want supportive devices to replace what your muscles are supposed to do. Thank you.
Thank you very much, Dr. Adeshola Odole. You can see that she's quite passionate about the subjects of today. We recognize our physiotherapy colleagues who are online, Professor Aderunke Akinpelu, the current president of SSPN, Professor Babatunde Adegoke. I want to give the people who are attending physically the opportunity to also ask their own questions. Dr. Nse Odunaya, please.
Thank you very much. I'm delighted to be here. I honor our older adult here and the older adult online. And I'm very glad to listen to this presentation. I'm not in orthopedics, I'm a physiotherapist, I'm in cardio. But this happens to people that are very close to us. My mother has osteoarthritis and has siblings that have, so I want to learn some things. I've been reading an article on genetic predisposition and contribution to osteoarthritis development. Yes, but I believe in God, like Mama said. I will not have osteoarthritis. In case I have, I'm learning so many things here, coping mechanism and all that. But I want to know what you're doing in Nigeria about thinking about gene therapy for osteoarthritis. The reason being that I've read articles that tell us 35 to 65 contribution is genetic. And I was just reading an article that talks about the chromosomes and the genes that are linked to osteoarthritis. And I really became worried. What can we do at the root, at the beginning, such that, because the burden is so enormous. And I've been talking to my mother and moving about and all that. And I know sometimes it's a bit tough because when you're used to doing things in a particular way, it's difficult to change. So what are you doing about that in Nigeria so that we could reduce the burden really, really drastically? And also, I observed that, yes, I also observed that there are other things about osteoarthritis care, and people here are mainly, the speaker is orthopedic surgeon, we have a physiotherapist, and I know that so many, when people come with osteoarthritic pain, they go to family medicine, they go to GOP, and if we don't have much collaborations at that level, the orthopedic surgeons know that physiotherapists are very important in the care of osteoarthritis. But what about, you are a doctor in your family, you are not in orthopedic surgery, you are not in orthopedics at all, and everybody believes that you're a doctor. You have to treat any problem I have in the family, and you're the first point of call. And you treat the patient, and you don't know that there are other people you have to collaborate with. I just want to suggest that this could go larger house, invite more people so that we get the knowledge and everybody will be blessed through this knowledge. I thank you very much for all I've learned today. Thank you.
With the kind permission of the national president, I want to thank all my colleagues here. Thank the director of the Geriatric Center who has spoken so many kind words, Dr. Femi Olowo-Kere. I began an NGO in 2010, which titled Initiative for the Management of Arthritis. And all I did was to go to the remote areas of Ibadan, went to churches, went to mosques, just to educate people about arthritis. And it was very rewarding. But along the line, as soon as I became the Chief Medical Director, for 8 years, it became dormant. And the essence of IMRAT is called Initiative for the Management of Arthritis, IMAT. We have CAP, we have, I mean, a lot of the patients still ask me, when are we going back? Dr. What's her name now? Elebute was a member of the team. And what we were doing was to go and educate people. And one phrase which Dr. Dole alluded to was a Yoruba phrase. And I tell them, if you have gray hair, what do you do? Oh, we dye it. Okay, so after 6 weeks, what happens? Well, the gray comes back. So what do? You want to use another dye? That's exactly what happens. So it's a cyclical thing. And at that point, they then ask themselves, oh, you mean I don't have a permanent cure? If that is the case, then I'm going to adapt my life and I'm going to live with it. And so the issue of education, not putting on weight, the kind of food you eat, was now making sense after they understood the explanation about the various types of arthritis. Now, to come to the genetic model, it is true. We were supposed to start a study with, I don't know what, I think he's a professor now, in Imrat. He has an English name now, I've forgotten his surname. But then we had samples of blood of patients who were in the dementia group that were supposed to use looking for this single gene mutation, okay? Where we're supposed to look at the genetic makeup of patients who have osteoarthritis in Nigeria. So they've identified what they call candidate genes. So we're supposed to now look through the samples to see if we can get those candidate genes in Nigeria among, the patients. So we had a group of orthopedic surgeons, rheumatologists, together with this gentleman in Imrat. That's a little bit strange. I can't remember his surname. Okay? Yeah? I can hear me right. And so he asked us to come together. So I called Dr. Ibukunde Deke, 2 or 3 guys from orthopedics, but unfortunately we have not been able to scale through. But now that I have a little bit of time for myself, maybe we'll go and see if we can identify those candidate genes which has been found among osteoarthritic patients abroad. You're right. You have a right to be worried because if your mom, if your sisters, your siblings, have come up with it, I can assure you that you'll probably be the candidate. You'll probably be the candidate that Dr. Moyeni was talking about. When they brought in chondroitin glucosamine sulfate, we told them you're not going to be using them for end-stage osteoarthritis. But for people who have a genetic predisposition, we don't know what the effect of that genetic deletion or alteration is. Is it that it's going to reduce the chondroitin sulfate in your cartilage? Does it reduce the glucosamine content of your cartilage? So if that is the case, so you're using chondroitin glucosamine upfront, technically you're trying to delay the onset of this. So that is the essence of all of this study. So you can always bring all of this jigsaw together. But most importantly is to work together as a team, and that is actually where the result is going to be like. Well, family physicians are the primary custodians of over 80 to 90% of patients. And so what the primary physicians do, or family physicians, they know the baseline of how to manage osteoarthritis. The baseline, they know. And so they do not go beyond their level. So, but if at the point they think they cannot cope, we don't expect every first stage, cases of OA to come to us. They know exactly what to, give and who to refer the patients to. It is when they then get stuck and they say, you know what, I have some people who live and, sleep over osteoarthritis. You can go see them. And then we do our own little bit. Of course, along the line, they must have been liaising with the physiotherapist. So it's a conjoint, or more or less, it's a multiple, effort to try and address this rather, ubiquitous and big monster. I'm not afraid of it anymore. The UCH has a hydrotherapy pool. I wish we can resuscitate the hydrotherapy pool. Because if you do, a lot of the patients will spend more time in the hydrotherapy pool and they will do excellently well. And then maybe I will now use the opportunity to inform Dr. Olowo Kere, the outgoing director, the new director. Right in front of me here, there's a hydrotherapy pool that I've already started with the drainage of water at about 7 feet underground. So the place is set now is just to do the normal, construction and put a shade on it. We're going to UI to meet those who do mechanical engineering. If we're not going to be using the lift, the machine, to try and lower them in, we want the guys in UI to design a chair that we can actually do hydraulic principle to lower them into the pool, and the physiotherapist will go in there. The hoist is okay because it is in physiotherapy department, but quite frankly, you may not need a hoist here to put them down, to lower them, but we can use a chair, mechanical. So we'll put all those design here, and I want to pray God that it will be feasible in our time. Maybe this is the time for me now to go out to source for funds, and to look for funds to see whether we can construct or complete the hydrotherapy people in the geriatric rehab center here. And then it's going to add more value. This one is designed separately from the one in physio. You can open the roof of this one and allow the water to be heated by sun. And so they will do well without external heating, of the water. I believe maybe you've just, more or less, pricked a part of my body now that I'm now talking. Maybe I won't retire until another year. Okay, I'll give myself a couple of months before I retire. Thank you very much.
Thank you very much, everyone, for being with us since 2 p.m. I would like to call on the National Coordinator of Medical Women Association of Nigeria, Dr. Gbemisola Daramola, to give the vote of thanks.
Thank you, Ma. It has been a very long afternoon, but a very interesting one, too. We have had an enlightening and educative webinar. I will want to start this vote of thanks by thanking our chairman, Professor Adenike Grange, for joining us online. Thank you very much, Ma. The chairman of the BOT, Professor Oyin, Elebute, represented by our daughter, Dr. Modupe Elebute Odunsi. Thank you very much, Ma, for joining. And by extension, all other members of the Medical Women Association of Nigerian BOT. Thank you very much for being a part of this program. The first national president, Professor Oyin, thank you, Ma, for joining, for giving us the opening prayer. Our special guest of honor, Professor, my teacher, Professor Temitope Alonge. Thank you very much, sir, for coming. I thank the erudite speakers, Dr. Richard Omoyeni and Dr. Adeshola Odole. Like the MC said, she's obviously so passionate about OA. Thank you very much for teaching us this afternoon and for sharing from your wealth of experience. God bless you real good. We thank our national president, MWAN national president, Dr. Adekemi Otolori. Thank you very much, Ma, for providing this platform. And our national coordinator for the Senior Members Forum, Professor Eniola Elegbe. Thank you very much, Ma, for conceiving this. I also want to thank our chief host, he's the outgoing director. He has, this place has become like home for M1 National Executive. We've used it so often. We really, really appreciate you, sir. Thank you very much. We wish you success in all your future endeavors. We also thank the immediate past national president of M1, Dr. Oseji, the national president-elect, Professor Rosemary Ogu, all state presidents of M1 that were able to join online. We thank all our senior citizens that were able to join, Professor Onodeko and many others. I can't remember right now. Thank you all for joining. And I'm not forgetting our physiotherapists, online and physically. Thank you so much for being part of this program. You
chairman of the BOT, Professor Oyin Elebute, whose birthday is tomorrow, and we are doing this in honor of her birthday. Excuse me. I thank God for the chairman of the coordinator of the Senior Members Forum, who thought it fit that this is a unique topic that will go around everybody. Thank you very much, Professor Elegbe. Thank you very much, our BOT chairperson. We like to do what we like to do best, and to say thank you and God bless you. The plaque for Professor Elebute will be taken to her in Lagos. She's not here. The same thing for our chairperson. The chairperson, Professor Adenike Grange. Many of you may not know her. She was my teacher. And the husband, too, was mentor for my husband when he was doing his house job in Lagos. Professor Adenike Grange is a passionate pediatrician, very diligent. She will work from morning till night. We students will even run away from the wards. I thank God that she was able to mentor many, and we are being fruitful. For this occasion, she has been with us for quite a while, and what a coincidence. Husband, orthopedic surgeon, we are discussing orthopedic, and the wife, the chairperson. Thank you very much, Ma, for breaking your sleep and agreeing to be the chairperson for today, and for your wealth of experience. Since the beginning of this tenure, even with the last tenure, you have been with us, mentoring us, particularly in continuous medical education. Thank you very much. Your sash and your plaque will be sent to the US. Thank you very much. Now, many of you don't know Dr. Olowokere. Dr. Olowokere has been with medical women for quite a while. If we go back to the days of Dr. Abiola Oshodi, she was strong, sick, and almost dying, and one of her children called on me, not knowing that I was going abroad. So another medical woman, Dr. Moboale, I just called her. Can you get me a doctor from Geriatrics that can treat Mama? But the treatment is different. The fellow has to go to her house and pick her up. She looked around. I said, I'll spare the car, because I was in the hairdresser's salon. And here was Dr. Olowokere. Do you know Dr. Olowokere left UCH with the car, got home, convinced Grandma Abiola Oshodi the need to come to the hospital, and that extended her life for another 2 weeks. Please give him a round of applause. How many of us, senior consultants, professors, will listen to a young resident telling us to go to a home to do a domiciliary? We say thank you very much. And now that we have construction of NME House, what would we have done without this geriatric center? We now appreciate the NME building. We have nowhere else to go, and he was kind enough to usher us in last year. And since then, he has been open to us, partake in our webinars, and assist whichever way he can. Thank you very much, sir. Because of that, we want to decorate you. No, just don't worry. Yeah. What you like to do best, Professor Elegbe, please, can you come and decorate him? Yes, he will be around, and he's getting his own too. So on behalf of medical women, we'd like to decorate you as an MWAN champion. You have done for us what many cannot do, and you are still doing it. And we are able to say you are an associate, and you are an ambassador and everything. Thank you very much. Thank you. You are a he for she. So we wish you more laurels wherever you go. You have had a success.
I want him to be up.
Okay. We wish you successful years ahead, and I know the sky is the limit. By another 10 years, should we say, all the 6 geopolitical zones, at least we have geriatric centers. We all want to grow old. So let us join him and the government to do the needful now. Thank you.
Your own plaque was not ready. Bring it.
Another he for she. Please, when it comes to Professor Alonge, tell me when to stop. Tell me when to stop. If you want a dynamic, diligent, progressive, and Amazon, look for Professor Alonge. If you want a humble person with sense of direction, call for Professor Alonge. And if you want somebody who obeys the oath of medical profession, who respects seniors, call for Professor Alonge. Let me give you an example. I was going to Abuja in a plane. We landed. I didn't know I was in the plane with core of CMDs. They had a meeting in Abuja. And somebody just came behind me, just took my bag and my luggage. I said, no. This is part of dressing. He won't agree. The other one, he carried my luggage. He waited till he collected the other luggages from the luggage rack and gave them to me at the inspection site. Who can do that? And he was introducing me to other CMDs. I don't know what to say. Again, when I was president-elect in Ibadan, here under Professor Shokunbi was president, and she was very busy. He granted us courtesy call, and all what we listed, he tried to assist. And Professor, what is it now? Otegbayo was his deputy. They all assisted. For this and many. And again, you have inter-collaboratory support between UCH and government. Who is the brain behind it? It was under the chairmanship of Professor Akinkugbe on the side of government and Professor Alonge in UCH. Today we have a functional collaboration. We say a big thank you for this and more. And when we decided to have our first webinar, we looked around, we said, what is affecting us? We said COVID. Who was there again, or who is there again? Professor Alonge. In fact, at that time, he couldn't finish the meeting for another meeting. For this and many more. And when I had to call him for this, I must say I was shy. Because I know this is his field. How can I talk about orthopedics and not involve Professor Alonge? Who owns orthopedics? We say a big thank you for the knowledge. May the Lord continually anoint and increase you, and may you reap the fruits of your labor. We thank you for your mentee here and so many other things. So in medical women, we like to say thank you. We like to appreciate. One, we are saying you are
another champion.
You are an MWAN champion, a worthy champion of MWAN who has supported our cause all the way through, and we still look forward to coming for more. Thank you very much. And again, we are saying, is presented to Professor Temitope Alunge in recognition of your immense contribution and meritorious support for medical women all the time. May God bless you. Thank you very much.
Thank you.
Should I do ladies first? Okay, let me do MWAN first. Thank you. Dr. Richard Omoyeni. Thank you very much, Dr. Richard. I'm one of your own. I'm proud to say I have the burden of OA. And I'm proud to say when you want to marry a lady, look at their mothers and grandmothers. It applies to me. But when I was a young girl, I wasn't like this. I was an athlete. I was everything. But in old age, I have all sorts. In fact, the funny thing is I slept one day. I woke up and one of my fingers was bent. I took the picture, sent to my children, and said, yes, Mommy, you are aging. Don't use your fingers so much. Relax. But I thank God that is restored, because an orthopod told me it will not. Now, Dr. Richard Omoyeni, for taking the time, the energy, for being dedicated to go into research, to give us this knowledge that you have shared. We say a big thank you. We wish you more laurels. We are coming back again and again, particularly to our rural areas, because that is what MWAN stands for. Thank you very much. On behalf of medical women, we say we thank you. This is in recognition of your immense contribution as a guest speaker on the burden of osteoarthritis in the older people. Associate member of MWAN. Now, my sister, come over. Definitely, you are going for rural osteoarthritic mission. Now, Dr. Adeshola Odole, God bless you. Thank you for being passionate. Thank you for being a good physiotherapist. Thank you for giving me the confidence that I can come to you after this lecture. And thank you for the many works that you have done. We will say continue. You know, the gains are many, and you will reap your fruits here on earth and in heaven. And OA is not your portion. On behalf of the medical women, this is presented to you in recognition of your immense contribution as a guest speaker on the burden of osteoarthritis in the older people. Thank you. God bless the whole of the physiotherapy people. I know a long time ago, one of them saw me in the CMD's office when I was in UC. Said, why are you wearing this? I said, I love it. It makes me look smart. Said, what? It is disease. Go and remove it and be flatty. But now I realize they are correct. Thank you. Now, before I round up, I want to say a big thank you to everybody online and physical here, because without your support, we can't do what we are doing. And as I recognized some people earlier, I still want to recognize them. I want to recognize our first ever president, Professor Oluri, our founder, Professor Dunton, our BOT chair, Professor Elebute, all members of the BOT, all members of the National Advisory Council of MWAN, all past and present state presidents, National Executive Council, even female doctors that are not yet M1, I say a big thank you. And for our medical students, I say thank you. The NIMSA, they are coming on. And I wish to inform us all that M1 is very inclusive. We have the seniors, and that's why we have M1 Senior Medical Women's Forum. We have the strong middle stream, who are my supporters, the great supporters. God bless you. You too, you will get old in good old age. And we have the Young Doctors Forum. They are the present and the future. I say a big thank you to everybody. For the technical crew, I say thank you very much for coming. And for other people online, we can't do without you. Thank you very much. Thank you. We now come to the end of the program. Thank you.
Congratulations.